So we now welcome the next speaker, Dr. Chitra, who doesn't need any introduction. She's the face of ophthalmology, the scientific forum in almost all places. She's literally married to ophthalmology and an ophthalmologist. So she eats, breathes ophthalmology, and we just love her for her contribution to the ophthalmic scientific work, apart from being a great surgeon. So Dr. Chitra, I mean, we've spoken about now various situations, tried our best to do for a patient, but you know, you will always have this presbyopic IOL group who will have some or the other problem. So whether it's psychological or with their optical issues. So Dr. Chitra is going to talk to us about how to deal with those kind of spectrum of patients. Dr. Chitra.
A very good morning to one and all of you, and thank you, Parul, for those encouraging words. That I think those words make me more mad, and I'm scared of myself nowadays. So my due is to talk on managing unhappy 6/6 patients and in the premium IOL group. Believe me, today it is becoming a rarer problem than what it was before, and we have an overwhelming majority of very happy multifocal patients. And that is some message which I want all of you to take back with you, because there have been studies like the Concerto study wherein 94% of those patients wanted multifocal IOL in the other eye. The Harmony study, 88% wanted multifocal in the other eye. And there was a recent US FDA study wherein they found that 94 to 97% of the patients wanted multifocal in the other eye, compared to only 88% of them who wanted a monofocal. So things are changing, but then we need to address target emmetropia and a happy 6/6 patients. And how do we get there? Because of the paucity of time, I just want you to carefully look at all those 7 C's. And each of those 7 C's need to be addressed if you want your patients to be completely happy patients. And these have definitely an import, and if you address each of them, you're there. And also understand, you're not going to think that you are a perfect surgeon and turn a blind eye to it. Rather, you have to ferret after it and try to address that issue, because there is a problem there if the patient keeps coming back to you. And if you have answered that problem, you have won not just that patient, but that entire family and his friends. But you have to differentiate the problem. Now, is it a kind of a visual disturbance like glare or halos? Is it that the patient was fine initially and later developed the issue? Is it that the vision is disturbed for not for distance but for intermediate or near? These would tell you what is the kind of problem you have. So you need to trace it all the way from ocular surface, the refraction, to the IOL centration, to the PCO, to the macula, to find out where the problem is. But when you see there is a problem, don't be in a hurry to operate on the second eye. When you look at the cornea and the ocular surface, which is the first instant, we are all clear that there are different components of the tear film. Is it aqueous deficiency? Is it evaporative dry eye? Is it a meibomian gland disease? Each of these have to be looked into, and you have to understand that a pre-existent dry eye status could be there in these cataract patients, and some of it could get triggered by the cataract surgery. In fact, 60% of the routine cataract patients in the phaco study had a tear breakup of less than 5 seconds. And again, more than 80% had a positive corneal staining, and all the others which are written there, which tells you that you need to pre-operatively check whether they have a dry eye status. Make it mandatory in all your routine pre-op evaluation. It could be because of the cataract surgery itself, because of the denervation of the corneal nerve endings, because of exposure to microscope light in case your surgery has been long, prolonged phaco time, your preservatives in the post-op drops, some local surface inflammation which has triggered off by the cataract surgery, a goblet cell loss, or a meibomian gland dysfunction. And this was one patient who was fairly fine, had a Schirmer's of 10, and believe me, after cataract surgery, she came back with severe dry eye. You had to put her on topical steroid drops, tear substitutes. If you have an access to take a photograph of this meibomian gland dysfunction, you can even explain to the patient of what are the issues which are there, to make her get convinced that this is going to be a temporary issue which you could get her sorted out. So it mandates that dry eye workup is thoroughly done for all these patients. The other aspect is the chronic visual disturbance. It could be for positive dysphotopsia, those glares and halos, negative dysphotopsia, or a temporal shadow, or some of these are entoptic images. Let us understand that multifocal IOLs work on the principles of simultaneous vision. That is, one object is in focus, the other out of focus image is the causative factor. And what happens, that causes the halos to happen. And our visual system is not ready for multifocality. And how much of the light is taken up by the IOL which is being designed, and how much of the light is getting lost. Less of the light is getting lost, better the quality of vision, and that is what the modern IOLs are trying to address. Now, positive dysphotopsia is actually caused by the improvement in the IOL design, by getting a square edge truncated design, and by making the refractive index of these IOLs high to make these IOLs thinner. That causes positive dysphotopsia. Much of it goes with neural adaptation and time, so you need to reassure them, but you need to be sure that there is no other issue like refractive error or ocular surface disease or decentration, and very rarely you need to do an IOL exchange. And the problem is, IOL exchange cannot be done too late either, because what happens is, I don't know why that video is not working. What happens is that it shouldn't become that there is so much of capsular fibrosis that it's difficult to remove the haptic. Why is it not opening? Anyway, if the haptic is stuck and then you have to cut the IOL and prolong your surgery. Negative dysphotopsia is because of a dark shadow which happens, and there's again the similar etiology of high refractive index and the truncated edge design. What happens that the light which gets refracted from the edge of the IOL to the light which gets refracted from the back side of the IOL, there is a Lambertian light scatter, and that kind of a scatter is what causes that negative dysphotopsia. And some of the ways you can deal with it is to do a reverse optic capture, that is, get the optic out of the capsular bag, or you could place a piggyback IOL in the sulcus of 0 power, or rarely even the margin of the rhexis could cause negative dysphotopsia, when rarely you may even have to cut that rhexis margin. Invariably, they could also resolve. So what becomes important is that you need to talk to these patients, try to understand. It could be a centration of the IOL issue. Sometimes the haptic would have been broken. If a patient comes from elsewhere with a decentered IOL, you can never be too sure. You need to ensure during surgery that the rings are well centered and the first and the third Purkinje reflex are in line. You need to look at your angle alpha, but the present day in IOLs have a larger optic size, because of which an angle alpha being even 0.8 doesn't matter. Sometimes if the rhexis is not round, there could be asymmetric back contracture, there could be a zonular weakness, there could be a large angle kappa. Now this was a patient, 60-year-old, who came with that kind of a residual refractive error. Of course, he had needed a toric IOL rotation, but we also found out that he had a zonular weakness and a CTR had to be placed. It goes without saying that if you are on a femtocataract platform, I'm not showing you that video because of the paucity of time. There is the brilliance of the surgery, getting a centered rhexis on the capsular bag, and all the steps of the surgery definitely would take you forward. But again, as was beautifully addressed by Dr. Abhijit, you need to go after the PCO during the surgery. But if PCO is seen, you have to wait for at least 3 months before you do a capsulotomy, and you have to be sure whether it is the PCO which is causing the disturbed vision. In case the patient is so disturbed that you need an IOL exchange, you shouldn't have done a YAG capsulotomy in these eyes, and you to rule out a CME issue in all of these patients. So CME or any of those other macular disorders which has to be looked into, we should be doing an OCT pre-op for all these patients. So essentially, it is prevention. It is not the crazy patient. If you have seen most of the problems, you have to explain to the patient that the IOL power also comes not in 0.25 diopters and 0.5. So there are these issues, and the decision of the IOL exchange need not be the first thing which you do. Sometimes when you even spend some time and talk to the patient, you have won over the patient. And I think you have a range of IOLs. You have low ad IOLs, you have extended depth of focus, you have trifocal IOLs, you have continuous range of vision. You have the whole range. And if you are going to do an optical biometry for your patients, you're going to validate the results, as Dr. Abhijit said, you're going to treat the astigmatism, you're going to choose the right patient. And finally, if the patient has a small residual error, but the patient is happy, let him be. It is rather important that you have a 6-6 minus happy patient and then a 6-6 happy patient, unhappy patient. Thank you very much. There are more slides, but I thought I should stop. Thank you. I hope you all gained something from this talk, and I'm always there to help you outside. Thank you.
Thank you, Chitra ma'am. That was a wonderful talk and a lot of tips for us to handle a unhappy patient.